Let's learn how to code colonoscopies, CPT colonoscopies, and we're going to learn according to the guidelines. And you can find that information in CPT in the colon and rectum section and under endoscopies. Do you see how colon and rectum was indicated at the top and written in by us? Yeah, so we don't have to flip any pages to figure out that this is an endoscopy of the colon and rectum section. Just saying. Now, under this endoscopy section, this is where you'll find the scopes specific to the colon and rectum. This is where you'll find the tutors, or this is where you'll find the lower endoscopies, right? So let's just take a quick look. We've got a proctosigmoidoscopy, a sigmoidoscopy, a colonoscopy, and a colonoscopy through a stoma or an ostomy. So this is a colonoscopy through an ostomy, an opening a hole, or a colonostomy. Just saying. I know that's a tongue twister. All right, so let's just kind of review what these scopes can view. What can you see when a proctosigmoidoscopy is carried out? In fact, what can be viewed is what distinguishes these scopes. So a proctosigmoidoscopy is an examination of the rectum, and that may include a portion of the sigmoid colon. So let me give you a visual. I'm going to take my pointer and just kind of demonstrate what a proctosigmoidoscopy can view. So you can examine the rectum and may include a portion of the sigmoid colon, right? So maybe it stops here. Whereas a sigmoidoscopy is an examination of the entire rectum and a portion of the descending colon. So let's say that scope can view to about here or here, right? Now, a colonoscopy is the examination of the entire colon, right? From the rectum and may include the examination of the terminal ileum, but that is a colonoscopy. So, a colonoscopy is an examination of the entire colon from the rectum to the cecum, all right? And you might be able to view a portion of the terminal ileum. Now, what if you now, sometimes there are circumstances that won't permit the scope to advance all the way through the colon. So what do? Well, when that happens, you have guidelines. The guidelines are here, here, here. Yeah, we've got some guidelines. But coders, it's this decision tree, this colonoscopy decision tree that contains the guidelines too. And I found that it's very easy to not only reference the guidelines on this decision tree and also instruct the guidelines using this decision tree. So let's go ahead and do it. Oh, and one thing, I want you to remember that this is where the splenic flexure is, this little corner right here. All right? Just remember that it's going to be key. Essentially, this is how you code colonoscopies. And remember this splenic flexure. That's key. All right, so The decision to undergo a colonoscopy has to have taken place. The patient's there for a colonoscopy. All right. So either it's going to be a diagnostic or a therapeutic. Diagnostic is a quick, not a quick, but it's a look see, or it's a preventive procedure. Therapeutic is they're going in there to treat, or it was therapeutic and then they wound up treating. And I'm going to show you how you can distinguish the two. But either or, let's just start with diagnostic. Let's say the person's there for a diagnostic procedure, but the doctor inserts the scope and it does not reach the splenic flexure. If it doesn't, you are to code a flexible sigmoidoscopy. That straightforward. Let's say that they do go beyond the splenic flexure, but not to the cecum. So they go beyond, but not to the cecum. Anywhere but to the cecum. You're going to use a colonoscopy code, but you're going to append modifier 53. Now, let's say we have a diagnostic procedure. They reach the cecum. If they reach the cecum here, at least you will code a diagnostic colonoscopy. Now, therapeutic procedures. If this is a therapeutic procedure and they did not reach the splenic flexure, you're going to use the therapeutic codes. What is that? Removal of polyps, etc. I'll show you in a moment. And the same, if they go beyond the splenic flexure but not to the cecum, you're going to use the appropriate codes, but you'll need to append modifier 52. So if they carried out that therapeutic scope, they did that procedure, you're going to use the procedure codes and append modifier 52. And for this therapeutic procedure, if they got to the cecum and they carried out the colonoscopy, you don't need a modifier, just use those therapeutic codes. In other words, remember the flexible, even though they went in for that colonoscopy, it will be coded as a sigmoidoscopy if they did not get to the splenic flexure. All right. And just so you know, the diagnostic procedure is, you can tell that it's a diagnostic procedure because the code language has diagnostic in it. I'm going to show you momentarily. And it's a therapeutic procedure because this is the code where the procedures are being carried out. Let's take a look. All right, on the left, you have a colonoscopy. Let me get my pointer out. It says colonoscopy, flexible, diagnostic. Whenever it's a diagnostic procedure, then you use modifier 53. If it does not get to the cecum, right? So if that scope does not get to the cecum, you use modifier 53. On the right, as you can see, there are those procedures. It's a colonoscopy flexible with removal of foreign bodies, biopsies, submucosal injections, etc., bleed control. This code series and beyond is to be whenever this is therapeutic, and we know it's therapeutic because these procedures took place and you are directed to use modifier 52. And if you have the MCG, the FTRs are as follows, and these are the FTRs, the green that you see are FTRs that are coming in 2026, so you should not have them. So if you want to document them, definitely press pause and do so. Place all of these FTRs at the bottom of the pages of the corresponding codes. Just so you know, this is how you code a scope, any scope in the digestive system. Number one, the type of scope. Is it diagnostic or surgical? Diagnostic or surgical? Number two, diagnostic scopes are typically bundled in the same surgical scope. In other words, you cannot code this diagnostic scope along with this surgical scope. No. All right. Number, wait a minute. There might be something that overrides this. Oh, it says it right here. Do not report it. Okay, don't report these. There you go. All right. Also, number three, diagnostic scopes performed with an open procedure are coded separately. So you can code this diagnostic scope with an open procedure as long as it's not related. Just saying. All right. Number four, if the intended colonoscopy does not reach that splenic flexure, coded as a sigmoidoscopy. Number five, for colonoscopies, use modifier 53 with 45378. So this is diagnostic. And for um, for therapeutic, use modifier 52 for therapeutic when they carry out procedures. Number six, be aware of Medicare, those HCPCS level 2 codes. If a patient is on Medicare, you are not to use these codes. Use HCPCS level 2 codes, the appropriate HCPCS level 2 codes. All right? How do you know they're on Medicare? Because the documentation says they're on Medicare. It is not based on the patient's age. Number two, code based on the anatomy viewed, not the scope. So you got to pay attention and just use your tree and you're good. Number eight, separate procedures are coded separately. Just remember the separate procedure rule, and that's it. Let's go ahead and test our knowledge on lower endoscopy coding. Of the following answers, which best describes the encounter? A, 45330, B, 45378 with a 53 modifier, C, 45378 with a 52 modifier, and D, 45300. A 58-year-old female was scheduled for a colonoscopy due to a history of chronic constipation. The procedure was performed under moderate conscious sedation. The endoscope was inserted through the rectum and advanced through the rectum and sigmoid colon. However, the procedure was terminated at the sigmoid colon due to significant looping and the patient tolerated and the patient's intolerance to further advancement. Wow. And this patient was under moderate conscious sedation. Wow, wow, wow. Okay, coders, your time has already begun. Okay, coders, if you need more time, go ahead and press pause. Now, these are my keywords: scheduled colonoscopy, chronic constipation. The scope was advanced to the sigmoid colon and it was terminated at the sigmoid colon due to significant looping. So maybe you have a few more keywords, but these are mine, and I'm sure yours are perfect. Now, let's go ahead and take a look at, you know what I want to do? I just want to kind of outline what took place. All right, so the doctor inserted the scope and advanced the scope about right here. So he terminated it right here. He could not get it to the splenic flexure. That's important, right? Because we looked at that colonoscopy decision tree, and that splenic flexure is key. Now, let's go ahead and solve. All right? And pretty much guidelines are going to drive the answer. Yeah. And remember the splenic flexure here? that scope didn't go that far, and let's go ahead and look at this decision tree. Whether it's diagnostic or therapeutic, if the scope did not reach the splenic flexure, then you're going to code a sigmoidoscopy, right? So let's look up our codes. If you are coding, we can eliminate on site B and C because it tells you that you're not going to append any modifier on these codes, right? On the correct code. So, number one, we're not coding a colonoscopy. Number two, these modifiers only belong on colonoscopies. So we can get rid of those two codes that are coding for colonoscopies with the appropriate modifier. And let's go ahead and take a look. This is indeed a colonoscopy 45378. In other words, this procedure was, although scheduled as a colonoscopy, a sigmoidoscopy was only performed. All right. So we got B and C out of the way. Now let's turn our attention to D. D is coding for 45300. This is a proctosigmoidoscopy, not a sigmoidoscopy. So we're going to get rid of D. And our answer is A. Coders, if you said A, outstanding. And also coders know too that this decision tree, this is guideline. Yeah. And while we didn't put it in the FTRs because it's just so much to consume and it's better viewed as a visual. And I think you're going to get it. Indeed, you do. All right. Let's move on. And this concludes our presentation on how to code a colonoscopy CPT Digestive System Guidelines by AMCI. Until next time.